Hello and welcome to ULHT. Here is a quick overview of an important aspect of antimicrobial review. You will come to realise that the antimicrobial team at ULHT like making bite-sized videos. There can be a lot of information to digest when it comes to infection management and can seem quite complex at times, but this session will help understand how to work through the dreaded decision of IV to oral switch. Remember, correct use of antibiotics saves lives. The aim of this presentation is to raise awareness of when to switch antibiotics from intravenous to oral route. We will look at the benefits and limitations of using the IV route, and then go through a simple but specific set of questions which will help you make the decision with confidence. When a patient first presents with severe infection and acutely unwell, one of the key considerations is sepsis. Sepsis is a state of system shutdown due to overwhelming infection. Whilst perfusion to the vital organs is prioritised, perfusion to the skin, soft tissues and gut are compromised. If there is not adequate blood flow to the gut, then absorption of medication given orally is not going to be reliable in terms of extent of absorption and/or rate of absorption. Not good in a life-threatening situation. Giving the medication directly into the bloodstream bypasses both of these uncertainties. Hence, benefits of using the intravenous route include a rapid therapeutic effect and delivery of reliable and accurate doses. The IV route also allows administration of larger doses that may not be tolerated well by the gut. It is a useful route in patients who may be nil by mouth, or if there are issues with taking oral medication reliably, due to mental capacity for example. IV administration of antibiotics have minimal to no discomfort if there are no complications. The intravenous route does come with its limitations. I'm sure in your clinical experience you have come across patients with difficult intravenous access. Whether due to poor vasculature or the patient removing the cannula themselves, having to repeatedly gain access can be a challenge when managing a patient. Those who require numerous medications via the IV route may also have difficulties, for example, needing to administer IV antibiotics and fluids simultaneously, but there is only one working cannula. Where several critical medications are needed to be administered urgently, this does present a dilemma in what to give first, as well as many complexities such as incompatibility or fluid overload. So there are many reasons to regularly review potential for removing some of the competing interests on the IV line. Cannulation carries a high risk of septicemia as you are creating an area open to the outside environment. This risk can be reduced significantly by cleaning the skin prior to cannulation, but environmental contamination is hard to keep at bay, hence there are limits to time for the line to remain in situ. Other complications include toxic or adverse reactions to the drug administered. The drug itself, or rate of administration, may also lead to damage to the surrounding tissues. This is known as extravasation, the unintentional leakage of fluid into the surround tissue. This can lead to sloughing, scarring and nerve damage and be a rather painful experience. If the patient is in an unfortunate situation where they have an allergic reaction or rapidly develop a serious adverse or toxic effect, the dose is irretrievable once administered. Preparation and administration of IV medication is open to error in drug selection, dose reconstitution, correct fluid, concentration and administration rate. So this is a risky process to balance against the benefits to the patient. Having IV medications generally means the patient has to remain in hospital to have them, so the length of stay is prolonged, and the risk of developing complications that may further increase the length of stay. Examples include hospital-acquired pneumonia, line infections or pressure sores, all adding to bed pressures and impacting on bed flow, A&E waiting times and ambulance waiting times, and mortality rates. So overall, there are a lot of compelling reasons to revert back to the oral route of administration once this becomes appropriate again. So, how do we go about making the decision to switch to oral antibiotics? You should consider the following questions to help make a confident and well-balanced decision. Has the patient been on IV antibiotics for more than 24 hours? If they have not, then the patient may need to remain on IV if looking very unwell and needing further information in order to make a decision, such as a new set of bloods, scans or imaging to confirm diagnosis or severity. Document the decision to keep going with IV antibiotics until next review. However, if the patient has been on antibiotics for more than 24 hours, the next question to ask is, Does the patient have ongoing sepsis? The perception of ongoing sepsis can be quite broad. In order to help hone down the decision, the parameters applied that fit in national consensus are as follows. Does the patient have 2 or more of the following, regardless of indication? A temperature of more than 38 degrees Celsius or less than 36 degrees Celsius. Tachycardia at more than 90 beats per minute. Tachyapnea, more than 20 breaths per minute. WCC, more than 12 or less than 4. If yes, then the patient should remain on IV antibiotics for now. Document this rationale clearly in the medical notes. If the patient does not have ongoing sepsis according to these criteria, a further consideration that might sway things would be, is the patient febrile with an associated neutropenia? If feeling unsure about what this actually means, you'd be looking at a neutrophil count being less than 1.0 or significant immunosuppression anticipated due to recent chemotherapy, immunosuppressants, high-dose steroids, or certain conditions that confer poor immune response. If the answer to this is yes, then these patients should remain on IV, and we advise that they should be afebrile for 24 hours before switching to oral antibiotics. Document this rationale clearly in the medical notes. If the answer to this is no, then we can wrap up this aspect of consideration and move on to further questions. Does the patient have any of the following severe or deep-seated infections? Endocarditis, osteomyelitis, septic arthritis, meningitis, encephalitis, intracranial abscess. Severe infections during chemotherapy-related neutropenia, severe necrotizing soft tissue infections, Staphylococcus aureus bacteremia, cavitating pneumonia, emphysema, exacerbation of cystic fibrosis, bronchiectasis, inadequately drained abscesses, liver abscess, infected implants or prosthesis, mediastinitis. If yes, then the patient might need to remain on IV antibiotics for a prolonged period of time. Do not switch to oral antibiotics if there is not a clear plan outlining the time frame to do so. Check how long the patient is meant to be on IV antibiotics and ensure this is documented clearly on the prescription chart. If unsure of duration, seek advice from the antimicrobial team or microbiology. Document discussions clearly in the medical notes and cross-reference it on the chart for colleagues to find easily. If none of these apply, then we have some further unpicking to do. Is there any compromise of the enteral route? This includes the oral route, as well as the possibility of nasogastric or nasojejunal tube, which may be in situ or considered. If there are barriers to utilising the enteral route, document this clearly in the medical notes and review frequently as appropriate. Examples include where the patient is unconscious, where the patient is vomiting, where the patient is nil by mouth, in which case also consider time frame. Is it for just one dose or until the next medical review? Where lack of mental capacity creates issues with compliance, only if they are not having a reliable oral or enteral intake. Some patients will not tolerate IV meds instead, resulting in the need to consider earlier oral switch. Significant risk of reduced absorption, for example severe diarrhea or steatorrhea, with exceptions as oral antibiotic treatment preferred in cases of C. difficile diarrhea due to better contact time with inner lumen of gut. Where post-surgery patients are not tolerating more than 1 litre of oral fluids or not having oral intake at all, as this suggests risk of gut function may not be running as it should be, where there are issues with mechanical swallowing disorders. If yes, then the patient should remain on IV. Document this rationale clearly in the medical notes. If no, then let's move on. Has the patient shown signs of clinical improvement? Clear parameters that can be applied for this are as follows. Apyrexial for the last 24 hours, heart rate been stable and below 90 beats per minute, respiratory rate has been stable and less than 20 breaths per minute, is blood pressure stable. Looking at blood tests, is their white cell count within normal ranges or at least trending towards normal? As long as they are not neutropenic, simply trending towards normal is satisfactory if all of the above are in check too. If the CRP is high, this is not always a marker of infection, so consider it accordingly. In the absence of any other reason for CRP to be elevated, is this also trending in the right direction? If yes, then move along to the next consideration. If no, then the patient should remain on IV antibiotics and seek advice from the antimicrobial team or microbiologist on call if deteriorating. Are there any clear contraindications to oral switch? For example, penicillin allergy, contraindications to oral options, cautions, multi-resistant organisms, toxicity risk outweighs benefits. It is important to note, limitations do not necessarily mean oral switch is not possible, just that options may be limited. Please ensure any such limitation is made clear in the notes to help guide choices. If there are such limitations, seek advice from the antimicrobial team or microbiologist on call if unsure of oral options. If there are not, then we have one last question. Is there any other compelling and clear reason to remain on IV antibiotics? Examples of reasons considered not to be valid include senior doctor's preference, awaiting senior review, patient wishes to stay on IV antibiotics. If yes, seek antimicrobial or microbiologist advice and document rationale. If no, take some action and switch to oral. To conclude, question each case with confidence. A switch to oral antibiotics can be an indicator that a patient is improving clinically. Use the question mentioned previously as an aid to help decide when to switch from the intravenous route to the oral route. And of course, if in doubt, get in touch with the microbiology team at your local trust.